to share, and so we can transfer our ideas, feelings, message, and information to one to another. So today I am playing this role, sender, and you all are receiver, but it is going to two-way process communication, right? Next slide, please. Next slide, please. Okay, the most important thing is communication. What is to hear and what is not being said. Like verbally, we have told to the patient so many words, but it is only 35%, and another 65% is all about non-verbal communication, like facial expression, our tone of voice, some movement, our appearance, our eye contact, and gesture, posture. Everything is important. Sorry. Maybe sorry, slide is not appear here.
Just a second, ma'am.
Okay. Yeah, so much communication barrier, no? So next slide.
Okay, ma'am.
Next one. Yeah, so need of communication. Can you please start slide mode so that all are comes one by one.
Ma'am, this doesn't work. This is a PDF file you have shared. So we can't have the screen share for a PDF file, ma'am.
Okay. So should I share again?
No need, ma'am. You can continue. We are already running out of time. So you can
Okay,
continue.
okay, fine. So, what is the need of communication? First, we have to share the information to the patient, whatever the state, the disease process, the prognosis, all we have to share to the patient and patient family also. Sometimes we have to reduce the uncertainty. Sometimes patient don't know that maybe he or she has not more time, so we have to tell the truth, facilitate their choice. Maybe they have their own choice that they wants to stay with their family members, don't stay hospital for long time, and another maintain relationship, because it is very much important for us that we have to maintain our interpersonal relationship with our patient and patient family. So next slide, please. So what are the barriers of communication? আমি কি বলছি আপনারা বুঝতে পারছেন? So what kind of barrier is this? Language barriers, right? So now I am talking in Bengali, so maybe most of the people are not uh, know the Bengali. So this is the barrier communication, like some patient factors. So here the patient is not willing to listen any words from our side. So that time some patient factors, maybe patient is drowsy or due to disease state, he or she is not willing to receive any message from us. And then illness factors, maybe patient is suffering from some dyspnea, means respiratory distress. That time he is not willing to communicate with us, so there can be a barrier. And health system professional factors, maybe we are using some professional jargons or our professional language, so that patient is not interested to hear about us. So that time there can be a barriers. And health system factors, like maybe we have no much time, and patient already have other appointment, like to do investigations and others appointments, so that patient don't have any time. And so here will be the communication barrier. We have to tell more, but patient do not want to receive our message. So next slide. So now talk about effective communication, because effective communication is important in our setting, so that we whatever we want to share with patients and family, that should be effective, right? So next slide. First, assess what the patient already knows. Maybe patient know that he is in dying phase, or her or his disease condition couldn't be cured. So already he knows the stage of their disease. And next, we have to assess what the patient wants to know. Maybe patient don't want to discuss us with regarding their disease process or prognosis. Maybe he or she was fine with his or her condition. So we no need to tell them all the truth. Be empathetic. We have to feel the patients and family that maybe he or she is suffering from some life limiting disease, illness. So be empathetic. Next, slow down. Sometimes we are in hurry, so all information we want to give together, like, oh, you are suffering from this cancer disease and you are not have so much time now, already you have referred to palliative care settings, and now I want to counseling and breaking the bad news. No, slow down. Means one by one you have to tell to the patient so that he or she can understand. So next slide please. Ma'am, next slide. Yeah. So keep it simple. Avoid jargon. So many times we can use our medical terms, but it is difficult to understand for the patient, right? And tell the truth. It is very much important to tell the truth that whatever condition he or she is suffering from, we have to tell the truth. Be hopeful, because maybe there is no curative treatment for the patient, but we do care until the death, right? So, and be prepared for rejection. So many times we don't receive rejection. Maybe patient don't want to listen anything, but we want to tell the truth, the everything, because already ma'am told me that I have to tell the truth, but patient don't want to listen anything. So be prepared for rejection. Maybe patient don't want to listen to you. Okay. Next slide. So example of poor and good communication. So which one is good or which one is poor, like you? Anyone, unmute yourself and please tell me which one is poor and which one is good.
Communication is second one. First one is poor and second one.
First one is good.
Verbal communication. First one is
Good.
poor. First one is
poor.
Good.
Why first one is poor? Because here patient is not maintaining eye contact, face is, see, it is towards window side. So patient is not willing to communicate with us. And the second was is good communication, because patient and we are facing together and we are maintaining our eye contact, right? Okay. So next slide, please. So how we communicate, effective communication. So first, ask open questions, like we can ask patient, how do you feeling today? Maybe patient can ventilate ourselves to us that today I'm fine, and that's the thing, last time my sleep was well. So here we can ventilate to the patient, we can communicate further. Otherwise, if we ask that, is your pain better today, means if whatever he or she can say, if yes or no, so it is kind of close question, maybe communication cannot be further. Be empathetic, like sometimes patient will say you that, oh, I was scared when I am breathless. So you just tell, okay, don't worry, take the medicine and you will be fine. We don't say like that. Okay, I understand that that time you were scared. Okay, I have some medicine, ma'am, please take this. Maybe your distress will be reduced. Okay, be sensitive while telling the truth. Okay, patient will tell you that already doctor has told me that my cancer is not be curable. So what the point? So you are telling that, okay, don't worry, everything will be fine. We don't say that. We have to tell them that maybe, ma'am, your cancer will not be cured, but we'll do care whatever we can. Next slide, please. Ma'am, next slide. Okay. Always attempt to balance hope and truth. Uh, we couldn't say like this. Okay, your cancer is not curable, so no point to staying here. You can go your home. Go to your home. That's fine. We couldn't so much rude to anyone. So what can we say that? We can say, ma'am, already your cancer is not curable, but so many care, so many medicines we can give you or we can prescribe you so that you can get better comfort, care to minimize your sufferings. And if you want to go to your home, you can go. If any medical help you need, then you can call us or you come to our clinic. That's it. Next is maintain confidentiality and avoid unhealthy curiosity. Maybe patient will share some secret to you, like, oh, maybe this cancer, I know why it has happened to me. So that time you just told me, oh, okay, wow, why? We cannot be so much curious. We can say that, okay, ma'am, you can share everything if you want, and make sure them that you will keep everything confidential, right? And partnership between nurse and patient. Okay, sometimes patient is not so much cooperative due to pain, insomnia. So that patient, I don't want to take this medicine. So that time you couldn't say like this that, okay, if you don't take the medicine, the pain will remain same. You couldn't say like that. You can say, ma'am, I understand, but your pain will reduce if you take the medicine. Your pain is due to your disease condition. So we'll try to have medicine and then we'll review your pain is gone or not. Next slide. Okay, be an active listener because so many times we are talking so much. So be an active listener. Next slide. So how we can be an active listener? First, we greeting and sitting. Hello, Mr. X. How are you today? Then we have to sit so that we make them feel that we are with them. Face the speaker. So many times, if I am taking this session like this way, okay. So you are not happy with that, no. So we have to face this, face together. Then we have to make eye contact. Otherwise, sometimes patient is telling some truth or something, and you are doing some, you are stucking on your phone, or you are doing, oh, okay, then you not maintaining your eye contact, right? So you have to maintain eye contact. Nod your head means sometimes patient will say some information to you, and that time you have to yes ma'am, yes ma'am, but not unnecessary interaction. No unnecessary interaction, but you can nod your head to make them feel that you are listening whatever he or she is telling to you, right? And focus on what is being said. Sometimes we are focused on whatever we want to say to them, so it is very important to focus on what is being said, right? So next slide. Okay, repeat back. Sometimes patient is telling so much things, and sometimes patient is maybe diverted, so we have to repeat back. Okay, already you have told me that you are suffering from this disease, already you know, right? So what are the condition already you are suffering from, already what are the problems you have? So then he or she again repeat back to the communication. Ask question. Sometimes we have to clarify that whatever they have told to us, that is already we understand or not. And keep hands and feet still, otherwise so many times we feet is moving, hand is or like this way, so it is not, it cannot be eye effective. Maybe patient don't understand that we are listening. And wait for the speaker to stop before speaking. So many times we have too much thing to tell to the patient or patient family, that time which okay, already I know everything, already I have listened everything, so now I'm telling. We don't do that. We have to wait. We have to wait, and we have to wait for the speaker. Then after finishing, then we can add some. Okay, already I have told that avoid unnecessary interruption. Otherwise, patient will not happy to share something with you. Okay, so it is important. So next slide. So here is a scenario. Mrs. Polly Das, 40 years, female, has breast cancer which has spread to her bones. She has pain which is being treated by medicines. Her son died in 3 years back. Her husband is not very supportive. So Mrs. Polly, nurse, I am so worried. I can't sleep properly and pain on back is still there. So here are so many options, and which of the above response do you find appropriate? Why? And what do you find appropriate with other responses? Can you please tell me? Please unmute yourself.
Have you taken medicine today?
Okay. Then okay, I just no ma'am. How type of communication is this? Question is this? Is it closed or open? Anyone
It's
from the
It's an open question.
One question, ma'am.
how have you taken medicine today? No.
Can you tell me more about
Which one and why?
So I would say the best response would be, could you tell me more about what you feel? Because that's an open-ended question. It's looking for more information. The other questions are either closed-ended questions, meaning they either have a yes, no answer, or they're just statements that sort of assume that we already know everything that we need to. like, don't worry, you will be all right soon, or I will prescribe medications to make you sleep. Like maybe they do need medications to help with sleep, but it's good to get more information first. So because of that, number 4 is the best response.
Yeah, clap for her. Absolutely, because that this type of question means open. So ask open question to the patient so that they can communicate or ventilate with us. Right? So next slide. So here is our patient. The first one is Saraswati Ojha. She was staying with us for a long time, and she was suffering from pain. Maybe that was mental pain, stress. So after a communication, now you can see the happy face. And another one is Koruna Nath. Actually, she was a music teacher, but she stopped to listen music after listening the truth that she was suffering from cancer. So here with us, she started to listen the music, and finally, maybe she is not with us, but happily she lived her last days of her life. So thank you. That's all. If you have any questions, then you can ask. And I would like to request Sister Shiva to tell more thing to us.
Thank you, Tania, for the presentation. Anybody have any doubts on this communication part? I know the communication you have done in life every time, every minute, every second. So anybody have any doubts on it, please ask her.
Yes, I have a question.
Yes.
Yeah.
About truth, telling the truth. Sometimes telling the truth is going to cause more pain. So I may be forced to give false hope for some time. What am I supposed? Must I tell the truth all the time?
What's your name?
Elijah.
Okay. Maybe we'll discuss the other session, Shiva.
Yes, yes. We have a session on breaking bad news session next day. So that time we will discuss more about that. See, if you want to break the truth to the patients, we have to listen their insight first. What they have understand about their diagnosis, and we definitely we don't give any false hope to the patients. Don't give a premature premature reassurance. So we need to give a truth to the patients, but certain conditions we need to learn how to break the bad news. We have to listen their insight first, and we have to arrange that area to share, and we have to prepare on that, and then what you have to share it, and so then if there is any emotions in between happen, how will you manage these kind of things we need to learn first, and then you have to break the bad news. So definitely don't give any false hope, and don't give any premature assurance to the patients. But if they want to, willing to hear their diagnosis, definitely we can, but it is the proper way.
Hi team, I'm Haley from Kolkata. Can I just add something in up here?
Yes, ma'am, you can.
Yes. So the person who is asking the question for giving the false hope, what we can consider ourselves is, do we really like giving false hopes to us? if we consider ourselves into that position where the patient actually stays. So if not, if we don't expect false hope from others, then we will never give a false hope to others. Thank you.
Thank you, ma'am. So as ma'am said, always you have to think about the patient side and you have to place yourself into their shoes and then you have to start telling. So if
Be
they are,
empathetic.
yes, if you are not able to tell the truth, just listen and tell them that I'll come again. That kind of things you are, don't give any false hope. You are perfect. Your disease is that perfectly all right. It will maybe you will get well soon. That kind of things is not good because after 2 weeks that symptoms will be worse and they will be thinking like, okay, 2 weeks back this history is saying like my disease is get well soon. By disease is you will get well soon, but my symptom is get worse now. So that kind of things that you have to do one thing and you have to listen. Communication, from the communication part, you have to learn one important thing is be a good listener.
Yeah. Listen,
Okay.
listen.
You have to listen and that then you have to get an idea. Just think about yourself. If you have a severe headache, if you have a family problems, or maybe in your working areas problem or any hospital issues there, definitely you will develop a headache. Maybe other problem also. If you have if you have a severe headache, what you have to do? You will take paracetamol, or you then the next thing is you will find a person to that to share your emotions, right? If you have a good friend in your uh, hospital, definitely you will try to share. Definitely, if she or he is a good friend, that good friend will understand your emotions from your face. Then that best friend will spend at least 10 minutes for you for listening your problems. What is the next thing? You will get a mental relief. Okay, so after you're sharing that, maybe only 10 minutes you will take to share your emotions to your friend. So I have this much of stress there. So because of that, I have developed severe headache, that kind of things. So this is how our patients is also going, because nobody is there to listen their worries. We are busy for that. For nurses, we are spending most of the time with the patient. So we are the only persons to be a good listener for the patient. So try to listen their problems, try to understand their problems, and also if they have a psychosocial issues there, definitely the physical distress will be increased. So if you have listened to the 4 aspects like physical, emotional, social, and spiritual aspects, definitely we can able to improve the quality of life of the patient and their family. Not only so, patient is also important. On the other side, the caregiver is also affecting a lot, because once one person will get a diagnosis, will get an incurable illness in a family, that whole family will be affected. The caregivers and maybe really close relatives also affecting. So you have to give a proper support to the patient caregivers too. You have to listen their emotions too.
Because we are team, nurse, patient, and family, right?
Yes. So, and also we have a good teamwork. We need a good teamwork for improving quality, because if they have a psychosocial issues there, if we our duty is to find out whether they have a psychosocial issues or any other problems, then you can try to include the social workers or a psychologist into the team. Okay, in the patient care, so that the psychologist or a social worker will elicit more problems. And so once we elicit their problems, we can see how we can help the patient and family.
I have a question.
Yes.
If patient not able to speak their problems, so how can effective communicate with him? Or
Patient wants to know to anything from you.
no, ma'am. When we question to the patient regarding their health problem and other, so
So
how we
non
can understand their emotions and their problems if patient not speak, not able to speak.
35% is verbal, right? And 65% is non-verbal. So sometimes maybe he or she has some mental pain, mental stress, anxiety. Maybe she is in depression. Maybe she that time she is not able to tell you anything. But her or his gesture, posture, we can assess if there is any pain, any sufferings, any discomfort. If patient is in dying phase, he or she is sleeping peacefully. That time we can assess. Maybe he or she has no appetite, poor appetite, and he or she has no pain, any suffering. So that time we can understand. But if he or she is suffering from any discomfort, that time through non-verbal gesture, posture, uh, that time we can assess posture, everything. That time we can assess.
Okay, ma'am. Thank you.
And one more thing you have to do is, so you have to find out why they are reluctant to speak. Always try to identify the cause. And if the patient is not able to talk, not willing to talk, you can talk to the relatives and find out the cause first. So once you identify the cause, then you have to go with that.
Yeah. Maybe there is some hidden truth.
Yeah, some
Yes.
some bad experience also were there. So you have to find out why they are doing like that. The patient is why the patient is doing like this, and you have to pay. After that, you will get an idea how to move forward.
Sometimes patient unable to speak due to the disease condition, oral cancer. Whatever.
Yeah. So what you can do is that time, if the patient is able to write down their problem, you have to give a sheet of paper and ask them to write down their problem. If they are not able to speak it. So if they are,
Maybe he or she has any tracheostomy tube. So that time, so many times patient will write their problems. So we can take this way, right, to find it out.
if they are illiterate, then what you can do is you can go with the non-verbal expression.
Yeah.
Non-verbal also they will communicate the
Actually,
expressions,
ma'am,
from the expressions, we can understand their emotions. Are they able to go? The medicine is effective or any other problems? You can able to, yeah.
Maybe some sounds like ah, nothing he or she telling, but some sounds.
Okay. So we have a small video on communication. After this, after you watch the video, please tell me what are the good things and bad things that will be happening there on video. You have to watch on that and take a points and please share it. Okay.
Mr. Arun Kumar is suffering from lung cancer. Radhika is his wife and caregiver. Asha worker Raji is visiting them at their home.
So tell me your findings. What are the good things and what are the bad things happened there?
Happen.
Sorry. Who will start?
No.
Everything is fine? Good?
No.
No, ma'am. I think this is not a good effective communication.
Not good. Okay.
Because
So she did not listen to the
Okay.
patient, lack of empathy, body posture, then
She scolded the relatives.
okay. She is in hurry.
hello,
Okay. Yes.
Asha worker was listening to the patient, but she was adding up her own problems to the patient, and there were a lot of interruptions in between.
Okay.
And the Asha worker was not being empathetic to the patient.
Okay.
Judgmental.
Judgmental. Blaming the patient and the caregivers too. Okay. So not only the patient, is for the caregivers also. Not give good diet. She has blaming the caregivers too. Okay. So not a good listener. Then she blamed the patient for smoking. So because of smoking, you have like this, all these problems, you have to be expect like this. That kind of the things were there. Assumptions. She has assumed few things. Okay. Very good, very good. So we'll listen the rest of the part. You can watch.
Avoid the following to
I hope you will get an idea about bad communication. Now I'm going to show you a good communication video. Then you can watch again and please respond after that.
Asha worker.
Do you want to share? Is there any difference?
Ma'am, please.
Yes.
Yes, ma'am. The communication was very good. This
Okay.
patient,
Okay.
yeah. Patient grading was good, yeah. This health worker touching the patient and see the check and this medicine and medicine dose. It is very good for patient and not busy with phone, yeah. When patient wife says this body damage for medicine, at that time health worker says it's not matter this. Yeah. This is point. And its finishing was very good. And last time when a health worker goes live there, that time it's a very big.
Okay, thank you. Good observation. Okay. Any other points? So from this video, one important things we should remember always is touch is a powerful tool, but we have to understand where and when. Okay, so if they have an emotional problem there, if they express their emotions, that time your touch will be very fulfilled. So you have to give a touch that time. That time the patients feel more comfort because they feel okay, somebody is behind them to care them and listen their worries and protect them. That kind of understanding is there for even a one touch. So, but we have to understand that where and when we need to do it. Okay. Any other points want to share?
Yeah, in second video in good communicating, when she's giving good communication, that time patient's behavior, patient's caregiver behavior also changed. They wanted to express more. Their facial expressions also changed. So we have observed that situation also. In the difference is in patients and patient relatives uh, expression also we observed.
Yeah.
So
Thank you.
how?
Yeah.
Okay, ma'am.
And how was the ASHA workers' face? You are muted. Yeah.
Her face also very good. Means if she is opening her mouth itself, the way of speaking, patient and patient relative, they can express more what they are feeling, what their actual pain. They are able to express by seeing that nurse Asha worker's attitude itself.
Yeah. So because of her posture and facial expression, they understand that, okay, this ASHA worker or a nurse is coming here for listening our worries. Then they start
sharing their
sharing their
worries.
emotions. Okay. So, and another thing is you have to maintain the confidentiality. If they tell anything in confidential, so you don't share with others without their permission. If you want to share that particular things to your higher authorities, first you do one thing, you have to go and talk to the patient and relatives and take permission first, and then you have to share that.
Yes. She checked that medicine box, doctor's prescription, and finally she told, I will take the permission from concerned doctor itself. So everything she did in a good way.
Yeah, yes. Okay,
Thank you, ma'am.
Hope you all understand well in communication. So we have a case presentation. Sujita will be presenting a patient story today. Sujita?
Yes, ma'am.
Yeah. So
very good evening to all, ma'am.
Yes. Good evening.
My name is Sujita. Presently, I am working as Senior Nursing Superintendent in Indian Railways, that is in Visakhapatnam. Actually, this is my first online class session, ma'am. So I am very much little bit fear also it's there to me. A patient, female, 75 years lady, she is diagnosed as septic arthritis left knee. She is also known case of hypertension and diabetes, chronic kidney disease, that is CKD and fifth stage. Presenting complaints, 75 years old female admitted with complaint of severe pain in knee, unable to stand or walk, swelling at left knee with severe infection, complaint of high grade fever with irregular recordings, that is more than 103 Fahrenheit to 99 Fahrenheit, it's recording. Means if anything she is taking oral medicine, IV injectables, it's reducing to 99 Fahrenheit. Because of lot of infection, it's not coming to normal. And loss of appetite, nausea and vomitings, irregular bowel habits, and also with reeling sensation. Examination on admission, patient appears pale, weak, febrile, and uncomfortable. Temperature we checked 103 degree Fahrenheit, heart rate 118 beats per minute, respiration rate 24 breaths per minute, SpO2 96% at room air. Her RBS random blood sugar levels 250 mg per dl. History of illness. Patient is known case of hypertension, diabetes, and on medication since 20 years. History of irregular intake of medicines and carelessness from family members. So that patient developed chronic kidney disease a few months ago and underwent dialysis for some cycles. After the correction of CKD, patient discharged a few months ago. But unfortunately, due to the negligence of family members, there was uncontrolled blood pressure and RBS levels along with the septic arthritis. Treatment and significant investigations. Actually, I'm very sorry to say, a very hurry I prepared this show and all. Spelling mistakes are there, ma'am. I'm extremely sorry for that. Treatment and investigations, fever profile negative, blood investigations, hemoglobin, her HB is 6.5 grams only. That's what patient is appearing pale. WBC count is 12,090 cells per CUMM. Because of that infection rate is high. Urea 76 mg per dl, creatinine 2.24 mg per dl, RBS 350 mg per dl. And we have done 2D echo. Patient non-cooperate for ECG. So directly we went for 2D echo. Her EF is 55%. Aortic sclerosis, trival AR, ectopics during study. Patient treated with higher antibiotics, that is in IV route, antipyretics, antiemetics, antacids, insulin therapy for controlling of diabetes, blood transfusions followed by iron sucrose therapy to correct her anemia. Regular dressings, changing position, ambulation, mobilization in wheelchair, latter we given. Medications started with a higher dose of antibiotics, injection meropenem 1 gram in 100 ml normal saline, intravenously TDS. And after that, it's reduced to 500 mg intravenous TDS, then BD, then it's changed to tablet ferropenem oral tablet 300 mg BD. Injection paracetamol 1 gram IV TDS and in between SOS also because of her higher grade of temperatures. And after that, slowly BD and it's came to OD. Now she is on tablet paracetamol 650 mg TDS. Injection human actrapid as per sliding scale before breakfast, before lunch, and before dinner, subcutaneous route. Injection Pantap 40 mg IV BD and SOS. Injection Ondan 8 mg for reducing nausea and vomitings, IV BD and SOS. Protein her antihypertensive drugs, diuretics, and CKD medications. Capsule B complex and vitamin C daily once. 2 units of PRBS transfusion followed by iron sucrose therapy. And later, after her HB corrected, capsule IFA OD. Psychosocial aspects. There is no financial problem to this patient because patient husband is he's an retired railway officer, so they are getting good pension and all. So there is no financial problem, but there is poor interpersonal relationships with the family members. Patient is in a depressive mode as her decreased love and attention by her family members. As patient is unable to stand or walk and became bedridden, she developed the feeling of dependent on others, which makes her feel as down. Main concern needs to reduce the infection levels first. After that, correction of anemia and increase the appetite levels and regulates the bowel movements. Daily dressings, taking care of pressure points to prevent the further formation of bed sores. Counseling to the family members regarding little bit concern and care, explanation of the procedures, treatment to the patient, and importance of cooperation for a better healing. Summary. 75-year-old female suffering with severe pain and infection due to the septic arthritis left knee with known case of hypertension, diabetes, and CKD treated symptomatically. When patient condition is improving, counseled the patient family members importance of providing attention, care, ambulation, and proper medications which gives a confidence in patient to lead a routine life without depend on others. Discussion points: dressing to reduce the infection and pain, educating the family members or caregivers about the importance of position changes and taking care of pressure points, importance of medications, counsel the family members how to behave with her and attention towards her. Thank you, ma'am. Ma'am, this is my first presentation and first online session also. Kindly excuse me, madam, if anything wrong goes uh, and anything I have unexplained improperly. Please kindly excuse me, ma'am.
No issue. It was an excellent presentation. You have covered all the points. I
Thank you.
hope
Thank you
that
so much.
this presentation is clear to everyone. So please, that we can go into the discussion points. You have to share your inputs first, and then we will give our inputs. So we will explore from that participants' ideas first. So here it's a 75-year-old lady suffering from lot of problems. She has some family issues. The relationships is not well. So we need to counsel the family members and patient. So this is the scenario. So how you will move forward? You have to share your thoughts first. And Tania, so do you. Please unmute yourself and talk, or you can put your answers in the chat box. If you have seen these kind of patients in your settings, how will you give psychosocial support, and how will you give counseling? How will you start?
If the bystander is unable to care the patient, we can provide a caregiver from any outside. Then we can give care to that patient perfectly. And because her partner is also aged, so we can help by this way.
Okay.
Yes,
Sony,
yes.
thank you. Any other options? Any other comment?
I just have a question. How is her diabetes being managed? I noticed her on the assessment, her blood sugar was high, and she's had kidney failure in the past, and unmanaged diabetes, of course, can result in poor wound healing. So is that part of the care plan for her as well?
Yeah. She was taking insulin also in home, ma'am. But some days, after some days, her daughter-in-laws and all, they left her, giving insulins also. They are unable, they were careless towards this old lady. Because of that only, RBS levels also high. Sometimes when she admitted previously, that time when dialysis sessions were went, her urea creatinine levels corrected, everything fine and discharged. But from that discharge time onwards, follow up, taking care of follow ups, giving medications properly, they neglected. Because of those negligence only, everything now that RBS levels, everything raised. She was on insulin, madam, mixed insulin at home, but they didn't give properly. And her husband also aged now itself. Patient is 75 years now. Her husband 80 years, like that. He also very old man. As one of the participants told, one caregiver they arranged at last finally for some money they are arranging for giving care daily.
Okay.
So now they are taking care of that patient.
Okay. Do you have a better care plan for that patient?
Actually, we are physiotherapist advices we followed, madam, and whoever giving the caretaker, we explained how to move the patient from bed.
Okay.
So that it will reduce the arthritis also, which moves she has to take for her knees.
Okay.
And proper diet plan also, how we will give diet, free small and frequent meals, not large meals. If anything, we will give full meals means she is getting nausea and vomiting. Na? So how to give little bit in a small frequent meals. So what and all we need to give because patient is she has to take renal diet and a diabetes diet also. So as per the chart, how that caretaker has to feed the patient. So now when they arrange the caretaker, that time onwards, she is improving. Means they are giving frequently meals, small meals. In between, they are changing the positions. Once her infection levels reduced, the patient also pain reduced. Main actually we planned for posted for surgery for debridement under spinal anesthesia, but because of the patient is not cooperative, patient attenders also not willing for surgery in that situation. So that by seeing her echo and that RBS levels, anesthetist refused to give anesthesia. So initially treated with all these systematically this IV antibiotics, antipyretics and all. After slowly reducing the infection, RBS levels coming down, a patient also now taking orally increased amount of food. So now patient is mobilizing properly in a wheelchair, in bed. In bed also the caretaker changing her position frequently. She is able to communicate with us. When she admitted, everything she kept her face like that, and whatever we are asking question, she was crying. That's all, only cry. But now she is able to saying a little bit with small stories also. I ate this thing, I ate that thing. Now I am okay. That words she is speaking.
Okay. Very good. So, Tania, anything you want to add?
Yeah. So here is an example of neglected patient, and that's why maybe she was suffering so much when she was in her home. But now, when he came to your place, that time she will respond better, and maybe here you also give some total care like physical, social, spiritual, mental health, so that patient actually palliative care is doing this. When patient family and patient will not take care of their self, that time they came to our place and stay with us for some days, then they return back to the home. But if negligence is continued, that time no point again he or she came to our place, and then will it is
Yeah,
happening
yeah.
also here.
Yeah, that's what we instructed the patient attenders, madam. See now what happened. We corrected a CKD levels, everything, and we sent her in a very good position. But she again readmitted like this. She now what and all went. If you are neglected like this only, more than like this, whatever now she is suffering, it will happen. So you need to be take care. Like that, this is one example they have seen. So like that we instructed, madam.
Yeah. Okay, that's it.
Okay,
Thank you, ma'am.
so from the patient story, we understand that there is a isolation and negligence, and you have to think about the patient side first. And if she is not willing to admit it in the hospital, how will we manage? We need a home care support. So we have to find out the volunteers. We have to find out a good washer workers around that area and you have to train the ASHA workers and volunteers what is palliative care, how to communicate with the patients, and at least in between they will go there and listen their worries, and they can able to find out their problems, and then based on that try to improve their problems. Like this here, they are this patient is affordable, and they will get a paid caregiver for that, and she will take care. She is the person to take care of that patient. So this is a that may be well of patients. But you have to think about the pure patient side also.
Yes.
Okay, if
Yes,
they
ma'am.
are in bed bound, yeah.
Whoever the caretaker, they has to depend on us only. Whatever we are teaching them, they used to follow those things only. So for that, we need to explain them and we need to educate them properly.
Yeah.
For the follow-up care.
Yeah, so we have to empower the caregivers, and so if you train the caregivers well, definitely they will take care of them well. So
Yes.
here what we do is we will try to manage the patient in their home. We will teach the caregivers first. If the symptoms are not controlled, or if they have a lot of psychosocial issues there, then if they are willing to admit it here, we bring the patients here, and as well as the caregivers. We train the caregivers and educate the caregivers, and then once the symptom is controlled, when we will send them back, and then we will follow up through home care. Our nurses will do the follow up. So that is what we were doing, the palliative care settings. We have an inpatient facility, home care facility, and outpatient facility. If they are able to walk, they can come here. If they are not able to walk, we will provide home care. If the symptom is not controlled in their home, we will admit it here, and once the symptom is controlled, we will send them back.
Yeah, we'll actually teach our patient family how to do lymphedema massage, how to do dressing. Actually, we have to train them so that they can take care of their family members at home. So because home is the best choices for everyone, no?
Yes, ma'am.
Yeah.
Okay, so we can wind up the session. From this today's session, I hope you will get some ideas for the communication, especially listening is one of the main area in communications. You have to listen their problems. Once we listen their problems, we can identify the cause, and then if they identify the cause well, then you can treat the patient as a whole. If you give a total care to the patients, definitely we can improve the quality of life of the patient and their family. Okay. So thank you, Tania, for the excellent presentation. Thank you, participants, for your interactions. So this session is very